We're gonna actually start dinner soon, so we can make a very organized line, single file. But we have the plates here to the right of the wall, as well as the utensils. And then afterwards, as you can see, it's buffet style, so you can serve yourself, and then at the end of the meal, we'll come around and get your plates and put it somewhere nice and neat. So either way, anybody can get up and go. I guess hungriest goes first. But go ahead. Everybody is free to get up and get food before we start the lecture. Thank you.
Defect, but on top of that, there's a mucogingival defect. And the mucogingival defect, don't do the implant if there's a mucogingival defect. If you have a bony defect, mucogingival, that implant is going to fail for sure. So we're going to correct the mucogingival defect with this one. And he had a ceramic implant on this one actually, a zirconia implant on number 7. So this is the tissue. You see the unattached tissue goes all the way into the palate. So this is after, well, this is before, this is after. This is when we did the tissue graft, the strip tissue. It's kind of hard to see. It's not easy to take photographs when you're in the middle of surgery. But you know, that's a habit I picked up when I was a resident back in the 90s, and I just continued doing that. And these photos come in handy later. You look at them, you see, you know, what you did right, what could be improved, what could be done besides that. So he does have a bony defect there. He has longer crowns, but he has the keratinized tissue. That's the one. That's what's going to make a difference there, long term. Any questions? All right. So even though if you may have some bony defects and you don't want to correct it, just make sure that you don't have a mucogingival defect. Okay, correct that. So these are the implants. That's the sinus graft, and this is the anterior, the ceramic implant number 7. This is ceramic implant. This is ceramic implant.
So for the ceramic implants, the osteotomy protocol is the same as with the regular, or
pretty much very similar. Yeah, you still have to watch the gums, but the protocol of placement is very similar, the bone foundation has to be good. It takes longer to integrate. You have to watch for that. Any pressure will make it fail. So you got to be careful with those. And this is the other side. We did the tissue graft on number 14 as well.
And is it fine if like some of the threads will be outside of the bone? I see that that's kind of like a soft tissue one, right?
Which one?
Soft tissue level?
This one?
The zirconia one.
This one?
No. The X-ray.
Zirconia X-ray?
Yeah. So like there's some threads like still kind of a little bit out of the bone.
Well, on most implants, you get bone loss to the first thread.
Yeah.
So that's normal. And with zirconia implants, because it's zirconia, it's very tissue friendly here. Yeah. You get pretty good attachment, very tight tissue, especially if it's
kind of like a soft tissue level. This one, right?
Right. Soft tissue meaning this is soft tissue here.
Yeah, exactly.
But you get attachment with the soft tissue.
Oh.
Yeah. Long junctional epithelial attachment. So it's not a connective tissue attachment, but you get attachment to the implant body. And there are articles on that shows it. And that's why you want to do zirconia abutments even when you do titanium implants. The zirconia abutments, you get better results. It's more tissue friendly. And then with the zirconia implants, this is one piece, it's all zirconia.
Is there any specific brand or just?
This one is a Straumann brand. I use Swiss Dental Solutions and Z Systems. These are the 3 companies that I use for the ceramic. And so this guy had implants done a few years ago somewhere else, and this was a couple of years ago. But when he came to see me, I could see he was complaining of some discomfort here. And so I told him, it's obvious there's no keratinized tissue there. So let's do a tissue graft. Because you can see, whenever he's talking, he's chewing, these muscles are pulling on the gum here. When you do create the keratinized tissue, you don't have that pull. So that's what we did. This is a strip of tissue, pre-gingival graft. And then you let the cells populate in. And this was 3 years ago. And it's all keratinized. And I saw him a few months ago, all good. So no discomfort anymore. So you deepen the vestibule and create a keratinized tissue. Those are the two things that will help with the longevity of the implants. This one I saw a few days ago. This is the one I told you about. One of the first cases. This implant was placed 20 years ago. But when you look in the mouth, there is no keratinized tissue here. So I removed the implant, and then we're going to do a tissue graft there. So that's one reason that over long term they can fail. There might be other reasons here as well, but that's one of the key reasons. She had some veneers, and then there was no keratinized gingiva on the canine. So the dentist told me, I'm going to replace these veneers, but can you create a little bit more coverage here on the root? This is just a temporary crown, a temporary veneer or something. And I said, yeah, let's try it. So we did a connective tissue graft, and so it healed. So we got 2-3 millimeters more coverage. And then she had the new veneers done. And this is 3 months post-op. That's the one right here. Right here. Oh, the after didn't show here. So the after. Oh, sometimes they disappear. Okay. Anyways, hello. For some reason, some of the slides are disappearing. I'm not sure if it's a virus. Okay. So she had some recessions, and she wanted to do a pinhole. Pinhole, you have to be selective the cases. And so pinhole, the original pinhole technique, there was no sutures, and you just create a tunnel, bring the tissue down, and then you put collagen membranes in there. So I just modified it. I added PRF in there and put sutures to hold the tissue down. So that helps a little bit better. So this is 1 month post-op. So this one had the worst recession, but the rest of them are right to CEJ, pretty good. And the premolars had more recession. So this is what she had before, this is what she has now, with just a pinhole. And but I have a lot of other cases that had 2-3 times more recession than this with pinhole. As long as you have enough keratinized gingiva, it works pretty good. Question? All right. So that's it for now, and we can go over some questions.
So why is it that pulse for the Lynette, you're saying like diodes don't work as well? I mean, I know you can do like pulse settings with diode, but you're saying like the ND-AG, those ones, I think are pulsed as well.
It's the pulse laser. It's like I don't know the exact numbers, but I think it's 1, 2, 3 million pulse.
It can go from 25 microseconds to 1,000 microseconds.
Okay.
So and then you can adjust the hertz, the power of the laser is a digitally pulsed laser, so allows the variable different settings to be able to accomplish
right. So it's the wavelength, because it penetrates the cells differently, and the being pulsing. So it pulse. You have the laser, and then 1 nanosecond later you don't have it, and then you have it. So in 1 second, you have so many pulse, that makes a difference at the cellular, at the molecular level. With the diode, you can't have that, even if it's pulse. The diode has a pulse switch on it, I've seen it, yeah. No.
But it's hot though. The diode is hot also, it burns.
Right,
It's not like
it heats up, yeah. Yeah, so it heats up. These can heat up too if you use it too much.
Okay.
But with the Nd:YAG and erbium YAG, it's just a different story. And they're very expensive. You know, all of those lasers are over $100,000. Right? How much are we now?
Q4 pricing specialist.
MSRP? They give you good deals, so. And the technology advances, it keeps changing. You know, I got my first laser back in 2012. Now that laser is changed completely. There are a lot of different features on it. And any more questions? Well, the good news is that you get your certificate. Go ahead.
Can you clarify the strip graph technique from start to finish? Because I'm not sure I understand the requirement. The strip graph, you're accessing the album
Right.
with a thin strip.
Right.
Looking after that.
You take the thin strip and you do a split thickness flat on the gum from the ridge. You have to carefully, so you told me you do some period, right? So you do a lot of cutting, so you do full thickness, right? Because you always do both. When you fit the periosteum, it's called full thickness. Split thickness, is between the tissue, between the epithelium and the bone, or periosteum.
So you're going to split thickness, move that up, and then place the strip along the length.
Right.
And it acts like initiates the keratinized tissue now.
The palate tissue is the hard palate, not the soft palate. The hard palate is keratinized, right? So it has it in the genes. So you put it there, and those cells will repopulate to create that specific tissue. So
Is that going to be populated down?
what's that? Yes, it does. Right.
That surface split thickness, you're not covering it, and you just keep it clean with like salt water.
Purchase. Correct. Yeah. Within a couple of days, the fiberglass will start moving.
That's a lot like burn victims that.
What like?
Well, I have a family member who had a severe burn,
Right.
and they take from the derriere, they put those wraps, and it just
Not very Any other questions?
So doctor, talking about that, so like the partial like thickness, right, the flap that you released, so where do you suture it? Like do you suture it like, because like it kind of like, will have like some length, right?
Right.
So,
But
do
the
you
suturing-
trim it or like what?
We can have another lecture on the suturing. The suturing is a little difficult. You have to do a mattress suture to suture the.
So you released it, so like now like this is like kind of
Right.
released, right? So what you do the next? You put that strip and then
You put first you suture the flap up. Okay, it's like the lip switch, you know, back in the.
oh, so you suture like that, whatever you released,
You suture it up. It has to stay up. Yes, you suture it up,
okay, and then
and then you put the strip all the way up there, and you suture that. That's the second layer of suture.
oh, okay.
So, and
But it like the one that you released is kind of a little bit longer, right? How you suture it there? It will be like a pouch, right?
yes,
Like a
a little bit. It's a suture going around the graft, go inside the periosteum and come back out, and then tie it down. If you come to the office, I'll show it to you.
Okay. Okay.
And
So one day I need to come.
we'll do a hands-on. Where is Mehdi? There is a guy there. He's one of the lab techs I work with, and there's iTero people up there. So we're going to do a digital scanning, digital flow course coming up in the future. So watch for that if you're interested in the digital flow, and then we'll do some hands-on. So we have another place where we can do hands-on course. So we're going to be doing that soon. We'll send you flyers and emails if you're interested in that. Then we can practice some suturing as well in there. And then we have, sorry.